Welcome all to the today's presentation. So today we continue with maternal medicine module, and today's talk for the discussion is multiple sclerosis and pregnancy. Okay, we begin it our quote Master MRCOG with concept-oriented clarity. So this multiple sclerosis, it's a chronic inflammatory demyelinating CNS disease, most commonly seen in women. It is around 2 to 3 times more common in females than the male. The onset is in reproductive age group, that is around 30 years of age. Generally, during the pregnancy, there is a decrease in the relapse of the disease, but postpartum, what we notice is that the disease relapse are increased. There are no major adverse effect on the long-term progression of the disease because of the pregnancy. There are no major or obstetric and neonatal risk. Okay, so there are different disease types which we should know. Uh, there are three types. One is RRMS, second is SPMS, and third is a PPMS. Okay, RRMS is relapsing and remitting multiple sclerosis. Okay, so that is the most common in 85% of cases. It is RRMS. Okay, so relapse and remission cycles are seen here. Then SPMS, that is a secondary progressive multiple sclerosis. Here, what you get is a progressive disability. It may have relapse. Then what you have third type is a PPMS, that is primary progressive multiple sclerosis. Here there is a progression of the disease from the onset and the relapses are rare. Okay, so there are what are the symptoms which are seen in the multiple sclerosis? They are divided into primary symptoms and the secondary symptoms. Primary symptoms are the direct result of the damage to the myelin and nerve fibers in the CNS. Okay, so they are divided into most common and the least common. Most common is the fatigue, then urinary incontinence or urinary retention, then numbness, tingling, pricking sensation, loss of balance, dizziness, and vertigo. These are most common. Other visual symptoms such as optic neuritis, and often that can be the only symptom in 20 to 30% of patients. There may be diplopia, blurring of vision, poor color vision. There can be acute and chronic pain, constipation or anal incontinence, spasticity, cognitive symptoms, mood changes, significant clinical depression, okay, mood swings, irritability, etc. These are commonly seen. While least common are the dysarthria, dysphoria, dysphagia, seizures, tremors, etc. These are least common. And the secondary symptoms, these are the complications as a result of the primary symptoms. Okay, so here the patient may have recurrent urinary tract infections. There can be poor postural alignment and trunk control and decreased bone density and resulting increase in risk of fracture. Okay, so these are the primary and secondary symptoms. Primary information gathering, we have to ask these symptoms to the patient. Okay, so what is the pathophysiology? Basically, it is an autoimmune disorder where there is a demyelination and axonal damage. Okay, so we know well that during pregnancy there is a shift of immune response from Th1 to Th2. That is, pregnancy is anti-inflammatory in nature. Okay, so there is a increased Th2 response that favors remission of the disease. What happens in the postpartum period? There are decrease in levels of IL-10 at term, and that leads to the pro-inflammatory response, and that is why in postpartum period what we get is a flare of the disease. Okay, so during pregnancy relapses are less and they are increased in the postpartum. This is because of the decrease in IL-10 level, interleukin 10 levels at term. Okay, so pregnancy induces a Th2 anti-inflammatory state, reducing the MS relapses, whereas postpartum immune rebound with reduced IL-10 increases the relapse risk. So you can say that there is a during pregnancy, this disease goes into the calm mode, while at and term as well as postpartum, there is an attack mode. Okay, so what is the effect of pregnancy on multiple sclerosis? So during pregnancy, relapses are reduced, but in first 3 to 4 months postpartum, there is an increase in the relapse rate. Around 20 to 30% increase in the relapse rate is seen in the postpartum period. And what is the best predictor for this postpartum flare? It is the pre-pregnancy relapse rate. Okay. So what about the breastfeeding and what is the effect of the breastfeeding? So exclusive breastfeeding minimum for 2 months or more, there is a decrease in the relapse rate which is seen. around 50% relapse rate are reduced just because of the breastfeeding. And what exactly the mechanism is not known, but the environment, hormonal environment, that is a decrease in GnRH and LH levels and increased prolactin, that favors the reduction in the inflammation, and that is why the postpartum relapse rate are less if there is a breastfeeding for minimum 2 or more months. Okay, and this is what we need to explain in our task in MRCOG part 3. Okay, so symptoms are worsened in pregnancy. Which symptoms are worsened? The fatigue, back pain, bladder and bowel dysfunctions, spasticity. There is a decrease in mobility. Okay, so clinical features, common and less common features that we have seen: the fatigue, sensory symptoms, visual because of the optic neuritis, balance issues, bladder dysfunction. These are common one. Less common one are the dysarthria, seizures, dysphagia, hearing loss, breathing issues, etc. Okay, so what is the effect of multiple sclerosis on pregnancy? Maternal, generally the fertility is normal. However, there is an increase in the voluntary childlessness, and this may be because of the fear of affection of the baby, maybe fear of the malformations in the baby. There is increased voluntary childlessness which is seen. There is increase in the cesarean section rate and operative delivery, and this may be because of the disability which is associated with this particular condition. As far as the fetal outcome is concerned, there is no increase in the rate of miscarriage, congenital anomalies, and the stillbirth. Preterm birth is slightly increased. However, low birth weight and FGR rate is increased in these patients. Okay, so pre-pregnancy counseling is the most important thing. So pregnancy does not worsen the long-term multiple sclerosis outcome. So planning of the pregnancy is required, and that is to be done in the remission period. So what we need to discuss with the patient, this will require stopping and continuing of the disease modifying therapies. Okay, we will discuss when to stop at the end. Okay, which drugs require stoppage, which drugs can be continued, and which drugs are contraindicated, etc. That can be asked as a SBA question also. In fact, last examination there were many questions on drugs. Okay, so we will go into the detail at the end of this discussion. Then we need to discuss about the risk of the relapse, drug safety, etc. Encourage smoking cessation and reassure that there is a low inheritance risk. Now, what is the antenatal management in these patients? It is a multidisciplinary team care. The team will include the obstetrician, neurologist, multiple sclerosis nurse, and the GP. Then special care points are, we need to send monthly urine for checking. This is because the urinary tract infection risk is increased. We need to consider thromboprophylaxis because the patient may be immobile, and physiotherapy plus fall prevention measures are to be implemented. Then fetal monitoring, consider third trimestral growth scan because the FGR risk is increased. Relapse in pregnancy, the diagnosis will be by MRI. However, gadolinium is to be avoided. Then treatment. Treatment includes corticosteroids either orally or intravenously. That is the treatment of choice, especially in flares. However, if the patient is taking long-term corticosteroids, we need to monitor the patient for development of the GDM and hypertension. Then what care is required in the labor and delivery? So mode of the delivery is decided by the obstetric indication. Vaginal delivery is safe. Increased assisted delivery may be because of the fatigue. Okay. From anesthesia point of view, epidural is safe, spinal is safe, nitrous oxide is safe. There is no increase in the relapse risk with the regional anesthesia. Okay, so intrapartum care, avoid exhaustion, assisted delivery if required, catheter if epidural use. Okay, then postpartum management, there is increase in the relapse rate. Highest is seen in the first 3 months. Breastfeeding we have to encourage because we know that that will reduce the relapse rate. Avoid if restarting DMTs. Okay, so breastfeeding, it will depend upon the disease modifying therapy which we need to start in the postpartum period. Okay, then steroids, safe in the breastfeeding. Feed for 4 hours. This when the patient is taking the steroids. Okay, then contraception, most methods are safe, essential if on teratogenic drugs. Okay, so disease modifying therapies, which are the relatively safe: interferon beta, then glatiramir. Okay, and they need to be stopped once the patient become pregnant. Okay, which drug the patient may continue? Natalizumab may be continued during the pregnancy. However, this is indicated in severe disease. And what are the contraindicated? teriflunomide is the contraindicated, it is teratogenic drug. We'll have the detailed table at the end. Okay. So what about the assisted reproduction? So if these patients go for assisted reproduction, there is increase in the relapse rate, almost 7 times relapse rate is increased, and highest is seen with failed cycles or GnRH agonist. Okay. And mechanism is that the inflammatory cytokine levels are increased, and most of the patients who undergo ART, they will be stopping their DMTs. Okay, disease modifying therapy is stopped, and there is an increase in the levels of inflammatory cytokines that will lead to the flare in patients who are receiving this ART. Okay, so the take home message is that pregnancy is protective, it reduces the relapse rate. Postpartum high relapse rate is seen. Breastfeeding will reduce the relapse. No increase in the miscarriage or congenital anomalies. Slightly increase in the FGR and preterm birth. Steroids is the treatment of choice for the relapse. Regional anesthesia is safe, and MDT is essential. Okay. Now let us talk about the safety of medication in pregnancy and breastfeeding. Okay. So there are various DMTs are used. These are disease modifying therapies, and we need to know whether they can be continued before pregnancy or require stoppage before conception, whether they can be continued during the pregnancy and the breastfeeding. Is there any need for contraception? Because these are the things which are asked in the SBAs. Okay, so interferon beta stop after the conception. For pregnancy and breastfeeding, it is contraindicated. Contraception after stopping is not required. No placental transfer. Early exposure is safe. Okay, there is no increase in the congenital anomalies, miscarriage, etc. Okay, so HGA and preterm delivery, they are not increased in patients who are on interferon beta. However, pregnancy contraindicated, breastfeeding it is contraindicated. Once the patient becomes pregnant, then we need to stop. Okay, same thing is about glatiramer acetate. So stop after conception. Pregnancy and breastfeeding. Pregnancy is contraindicated. Breastfeeding is cautioned. Then contraception is not required. There is no placental transfer. Early exposure is safe. Once the patient becomes pregnant, then we have to stop it. Okay. Steroids, preconception use is possible. Pregnancy can be used. Breastfeeding it can be used. Contraception is not required. It is mainly used for the flares. However, there is increased risk of GDM, hypertension, SGA, preterm deliveries, neonatal adrenal suppression, and patient will also require a stress dose of hydrocortisone during the labor. Okay. Next is a natalizumab. This again needs to be stopped before conception. It may continue if the disease is severe. Breastfeeding it is contraindicated, and the duration of contraception required after the stoppage of the drug is around 2 to 3 months. It will cross the placenta, especially in the third trimester. There is increase in the risk of SGA, fetal anemia, thrombocytopenia. Then teriflunomide, again it requires stoppage before conception. Pregnancy, the drug is contraindicated. Breastfeeding, the drug is contraindicated, and contraception will be required until the level is less than 0.02 milligram per liter after the washup period. Then the patient can conceive. The drug is teratogenic in animals. Okay. Then next drug is alemutuzumab. Again, this requires stoppage before the pregnancy. It is contraindicated during the pregnancy and the breastfeeding. The duration of the contraception required is 4 months. Minimal placental transfer is seen with this particular drug. So the next drug is fingolimod. This also requires stoppage before the conception. Pregnancy and breastfeeding, the drug is contraindicated. The contraception requirement is for 2 months with this fingolimod. Okay, it crosses the placenta, teratogenic, increased miscarriage and congenital anomalies. Okay, then mitoxantrone. This also requires stoppage before the conception and contraindicated in pregnancy and the breastfeeding. The duration of contraception is 6 months. It is gonadotoxic. Decreased ovarian reserve is seen. There is FGR and preterm delivery in animals. The methotrexate, stop before conception. It is contraindicated in pregnancy and breastfeeding. The drug needs to be stopped 6 months prior to the conception. It is a strong teratogen, increased miscarriage and characteristic anomalies. This methotrexate stoppage is given at different places, different figure, but in this talk they have mentioned about 6 months, so I have copied it from this particular talk. Okay. Then mycophenolate mofetil also requires stoppage before conception. Drug is contraindicated during the pregnancy and the breastfeeding. However, the contraception duration is only 6 weeks here. This is also teratogenic. There is increase in the miscarriage and anomaly rate. Then dimethyl fumarate requires stoppage before conception. The drug is contraindicated in pregnancy and the breastfeeding. No prolong required because this has got a short half-life. So no prolonged contraception is required. It crosses the placenta. There is no increase in the anomaly rate. Then cladribine requires stoppage before conception. Pregnancy and breastfeeding are contraindicated. 6 months contraception. There is limited data. Then ocrelizumab stop before pregnancy. Breastfeeding and pregnancy contraindicated. Contraception requirement is for 6 months. It is anti-CD2, process the placenta, and limited data exactly. So drug which requires long contraception around 6 months are methotrexate, mitoxantrone, cladribine, and ocrelizumab. So this requires long contraception. The short contraception is required for fingolimod around 2 months, mycophenolate for 6 weeks, minimal for dimethyl fumarate. Okay, so most drugs are contraindicated in pregnancy except steroids. Okay, steroids are safest for relapse treatment. Natalizumab may be continued in severe disease, and teriflunomide is the absolute contraindication, and washout period is required. So that finishes this particular talk on multiple sclerosis in pregnancy. Doctor, we have few SBs. Would you like to go through these SBs, doctor?
I'll try. A 29-year-old primary gravida with relapsing remitting MS asks about relapse risk during and after pregnancy. Which statement is most accurate?
What is the answer over here?
The answer is E. Relapse risk. D. Relapse risk increases.
C. Relapse risk decreases
Relapse
during
risk
Yes,
pregnancy
decreases
and
during
yes. Relapse
pregnancy
increases
and
risk
increases
decreases during the
postpartum.
pregnancy and increases in postpartum
increases
period. We have seen
postpartum.
pathophysiology.
Yes,
What is
C is
happening
the
in the
answer.
pathophysiology? Okay, there is a Th2 anti-inflammatory response. And around
Yes,
the time of at term and postpartum, the IL-10 levels are reduced. Okay, so that is what is the pathophysiology. Okay,
yes, sir.
yes.
C is the answer correct.
Answer is C. Pregnancy, Th2 state, decrease relapse, postpartum, increase relapse, 20 to 30% reduce. Doctor, continue the next.
What is the main immunological mechanism responsible for reduced relapse rates in pregnancy? The reduce is because of the uh, decrease in the. So what is the answer?
Yes, Dr. Sinchana, any
The
inputs from you?
Th2
Is,
should
is
increase actually. The
the Th2 cytokine
Th2 should
dominance
increase
increasing?
cytokine dominance. C should
C.
be the answer. Is it correct, doctor?
It
C
is
is the
C.
answer.
Okay. Pregnancy, there is a
Th-
Th2 dominance, anti-inflammatory, so that reduces the relapse. Okay. Bina, madam, continue.
Which is the strongest predictor of relapse in the postpartum period? Is C pre-pregnancy relapse rate?
Yes, pre-pregnancy relapse rate is
mm,
the predictor for the postpartum relapse. Okay.
Which
Continue, doctor.
statement which
Uh,
statement regarding breastfeeding in MS is correct? It should be C. Exclusive breastfeeding reduces relapse
C.
risk.
yes, almost 50% reduction is seen with exclusive
Yes.
breastfeeding. Minimum for 2 months if they feed, there is a tremendously decrease in the
Relapse
relapse
rate.
rate. Yes, doctor, continue.
Which of the following fetal outcomes is most likely increased in women with MS? The D. Fetal growth
D.
restriction.
Yes, because we need to
D
monitor
is
them.
fetal
For that,
growth
we need to monitor
restriction.
these patients on this. Dr.
Fourth
Sinchana,
answer.
from here onwards, Dr. Sinchana, you continue. Okay.
Yes, sir. A 30-year-old woman at 24 weeks presents with new optic neuritis. What is the most appropriate management? A. Start in interferon beta. B. Immediate delivery. C. Oral or IV corticosteroids. D. Start methotrexate. E. Avoid treatment. Uh, C.
Should be
Oral
C.
or IV corticosteroids.
So
C.
most commonly used are the steroids. Okay.
Yes.
Next, doctor.
Which statement regarding labor analgesia in multiple sclerosis is true? A. Epidural increases risk, relapse risk. B. Spinal anesthesia is contraindicated. C. Regional anesthesia is safe. D. Only general anesthesia is safe. E. Nitrous oxide is contraindicated. It is C. Regional anesthesia is safe.
Yes. So even if this is a demyelinating disease, the regional anesthesia is safe in these patients. Okay. Next, doctor.
A woman with multiple sclerosis undergoes IVF using GnRH agonist. What is the expected effect? A. Reduced relapse rate. B. No effect on disease activity. C. Increased relapse risk. D. Permanent remission. E. Reduced MRI activity. C. Increased relapse risk
Yes,
with
relapse
GnRH.
rate is increased because ART up to 7 times the risk is
7
increased, especially
times.
GnRH agonist with GnRH agonist. Next, doctor.
A woman with multiple sclerosis stops methotrexate and wishes to conceive. What is the minimum duration of contraception required after stopping? A 2 weeks, B 6 weeks, C 3 months, D 6 months, E 12 months. It is 6 months.
Yes. So
D.
whatever the figure is given here in the talk article that I have included here. Next.
A woman stops fingolimod and plans pregnancy. What is the recommended duration of contraception after stopping? Not needed 2 weeks, 6 weeks, 2 months, 6 months. D 2 months.
Correct. Fingolimod 2 months. Okay. So the option D. So pregnancy is protective, not harmful. Then postpartum, highest relapse risk. Epidural is safe. Steroids is the treatment of choice for the relapse. There is no increase in the congenital anomalies and drug washout period that can be asked as a theme for SBA. Okay, so that finishes our topic today's on multiple sclerosis. Thank you.